Hi, so my name is David Ford, and for my presentation, I chose to look at a topic that's really a pretty big issue in our profession today, and that is staffing. So I'm just going to kick things off with a quick video here.
It's very hard being here today. As a Dark Lord of the Sith, I'm not expected to express my feelings. And I have to say, I'm very burned out. Actually, literally burned out, because I'm 90% burned. I sit in the bed, I have to apply this Silverdine dressing to these burns, and I cannot. So I wait for the nurse, I hit the call like nothing, hit the call like nothing. I wait for an hour for a nurse. Why? Because they are understaffed. I do not blame them. Actually, I do blame them, and I'd destroy them if I could, but I actually blame the administrators for creating such a foolish staffing ratio. How are the front lines of medicine supposed to care for a burned Sith Lord when they have a Bothan who's been partially eviscerated in the room next to them? They have a couple of Jedi on vents over there, okay, on 5 West, and there's one nurse carrying a ratio, not only just a ratio, but the acuity. Have you ever applied Silverdine to a burned Lord of the Sith? It takes hours. They have one nurse, like 25 Jedi. It's boring. And then you wonder why I'm anxious. That's why I'm here. I'm just so... By the way, could I get a Xanax? My anxiety is 12 out of 10 right now. 12 out of 10, Xanax.
So this video just kind of illustrates some of the issues that nurses have to deal with in a healthcare climate where the supply of nursing care really doesn't meet the demand. So my presentation today is going to focus mainly on the role of nurse managers in staffing. But first I'm going to look at a little bit of the history of staffing in nursing. I'm going to look at what it's like today, and then I'm going to go into the technical aspects of how decisions on staffing are made, and then finally I'm going to look at the role of the nurse manager in all of this. So obviously, nurse managers have a huge role in staffing. It's really complex, and it's not always totally clear. So hopefully we're going to sort out some of that today. So at the beginning of the modern era of nursing, most acute care was actually carried out in a patient's home. Hospital care was mainly provided by nursing students under the eye of a nursing superintendent, after which graduate nurses would actually visit the patients in the home. After World War I, the acute care hospital, sort of as we know it today, became more and more prevalent with the introduction of technologies such as medical x-rays and aseptic surgery. So what this did is kind of force nurses from providing patient care in the home into the hospital, sort of beginning to take away their autonomy in terms of staffing. After World War II, health technology continued to progress, and now we're seeing technologies such as mechanical ventilation and things like that, which were able to keep patients alive well past natural limits. So what this did is kind of just made nursing care a lot more intensive. And most of the burden for this increased patient acuity was assumed by nurses. So later, in the 1990s, a lot of acute patients were sort of discharged to be treated as outpatients as soon as they were sort of out of the woods, meaning that nurses were really only caring for patients when they're at their most acute. So what this did is sort of increase patient turnover while increasing acuity. So today, this gap between nurses available and patient demand still exists. Current medical treatments are keeping patients alive longer with serious illnesses and comorbidities. And when that's coupled with an aging population, the truth is that nurse staffing is kind of reaching a critical point right now. So this graph just illustrates that as the length of the patient's stay has decreased gradually, especially recently, the number of nursing care hours per patient per day has gradually increased. This is an issue for a couple of reasons. Firstly, because the evidence shows that inadequate staffing is directly linked to poor patient outcomes. In addition to that, inadequate staffing also leads to nurse burnout and a lack of job satisfaction. So, in terms of staffing decision makings, these are usually made one of two ways. Centralized structures, or tall structures, are where there's a dedicated human resources or staffing department that makes all the staffing decisions for an entire organization. In decentralized or flat systems, individual unit leaders are responsible for making their own staffing decisions. Both systems have pros and cons, which I'm going to look at. So, centralized systems sort of allow a more balanced view of an entire organization, and as such, staffing ideally can be used more efficiently throughout the entire organization. So this system takes a lot of pressure off individual unit leaders to make their own decisions, but there are some issues. These kind of systems can be slow to react to change, and they can be kind of impersonal, and likely decision makers at this level won't really know what an individual unit really needs. So in decentralized staffing systems, decisions can be made on the fly, resulting in quicker reactions to change, quicker decisions. And on top of this, the people making decisions on individual units have a first-hand view of what that unit really needs in terms of staffing. But again, there are some problems with this system. When decisions are made individually in this way, sometimes the result can be overstaffing on one unit, while another one might be understaffed needlessly. So there are a number of different methods of making decisions on staffing needs, but most of them fall into these categories, which are professional judgment, patient classification systems and workload management systems, decision-making frameworks, standardized ratios, and finally, dynamic and shared decision-making. So professional judgment is kind of the traditional method of deciding staffing needs. It relies on the decision maker's knowledge, experience, and intuition as a healthcare professional. Some of the issues with this are that it kind of tends to ignore established evidence even as healthcare moves more and more towards evidence-based practice. And on top of that, sometimes we can see huge variations in decisions made by one individual decision maker to another. So patient classification systems are used to group patients based on things such as the acuity of their condition or critical elements of care that they require. After this, workload management systems are used to sort of determine the nursing hours of care per patient group, and from that, staffing needs are determined. So issues for this system are that it's a lot of extra paperwork for nurses to fill out, and often the recommendations for staffing are considered too high to actually be put in place. So this is an example of a workload management form. So it just takes into account things such as number of times that vital signs have to be taken per day, ability to perform ADLs, and other different procedures such as IVs, catheters, etc. So decision-making frameworks are actually more of an aid to decision-making than an actual method of determining staffing needs. They kind of encourage decision makers to take certain things into account when making decisions. So these can be valuable, but they're really more of a tool rather than an actual solution. So standardized ratios are government mandated, and they enforce a minimum number of nurses to patients. These were first instituted in California in 2004, and a later study determined that yes, it did increase the number of nurses to patients, but that didn't necessarily actually improve patient outcomes. So ideally, more research is needed before we decide one way or another on this method of staffing. Finally, dynamic and shared decision making is a process by which frontline nurses consult with those in charge of staffing decision making to sort out what's best for each individual patient. So an example of this would be Curley's synergy model, in which patient characteristics are paired with nurse competencies in a way that hopefully creates a mutually gainful relationship between the nurse and the patient. This is a really patient-centered approach, which is good, but the problem is that it's really work-intensive and it's kind of unlikely to be applied across the healthcare system. So the role of the nurse manager has really evolved and expanded over time along with the healthcare system, and today nurse managers can kind of be something of a jack of all trades. So they're responsible for administrative tasks such as budgeting, management tasks such as interacting with leaders of organizations, and obviously human resources tasks such as staffing. So one study showed that the various roles of nurse managers are kind of up in the air in terms of opinion of healthcare workers. This certain study looked at the roles that nurse managers fulfill from a point of view of nurse managers, RNs, assistant nurses, and heads of department. So these roles included a lot of different things, leadership, being a liaison, negotiation, among others. So there was disagreement universally about pretty much every single role. The only one that everyone agreed upon was that of the resource allocator. And that really just goes to show how important nurse managers are in making staffing decisions. So a lot of what nurse managers do in terms of staffing can be explained by management theories. For the sake of time, I've only chosen to look at three: classical management theory, human relations theory, and open systems theory. So classical theories are the older theories of management. They're very science-based, very process-based, and a lot of what nurse managers do can be seen in these theories. The various roles of the nurse manager align well with classical ideas of management in that nurse managers essentially carry out most or all of the classical functions of management as laid out by Gulick and Erwick, which were planning, organizing, staffing, directing, coordinating, reporting, and budgeting. However, only looking at the roles of nurse managers from a classical point of view really is sort of an oversimplification of their role on the unit, and that's where human relations theory comes in. So staffing numbers alone can improve patient outcomes. So not only should nurse managers carry out the administrative duties assigned to them, they should also be a part of promoting a positive culture on their unit. And they should be invested in creating motivations for the nurses on the floor in order to improve nurse job satisfaction and thereby patient outcomes. So one study in particular showed that nurse morale and job satisfaction actually increased considerably when nurse managers were seen as a positive role model on the unit. So the staffing function of nurse managers is one that is extremely sensitive to outside influences, and as such, open systems theory is very applicable. When considering staffing, nurse managers have to be aware of a whole host of outside influences. These can be simple and obvious things such as sick calls. Obviously, a nurse manager who's responsible for staffing is going to have to be aware of that and receptive to it in order to make the correct staffing decisions. But they can also include bigger influences such as patient outcome information or general emerging trends in healthcare. But the truth is, realistically, no single theory can accurately describe what goes on in such a complex and varied role within healthcare. So as future leaders of nursing, all students should be considering staffing as an issue. The truth is that there's no real clear way forward at this point. There's no magic bullet to solve the staffing issue. But as research and technology continue to progress, the best we can do is continue to strive for a solution. And at the center of all of this, we have to consider that the patient is always the most important thing. Patient safety will always come first, and that's really what the center issue of staffing is. We need to be making sure the patient outcomes are the best that we can do. Thank you.